For the next session, I would like Dr. Avnish, Assistant Professor Cardiology, to come on stage and take over for the next session.
So I kindly request Dr. Rajiv Agrawal sir. Dr. Ram Ashray sir. Dr. Piyush Saxena sir.
It is a pleasure to have Dr. Rajiv Agrawal sir, the senior cardiologist of the city of Prayagraj. Dr. Ram Ashray Singh sir, who is a senior physician, and Dr. Piyush Saxena is a professor and head of the Department of Medicine, Motilal Nehru Medical College, Prayagraj. We request you to invite our next speaker of the day.
Good evening, everyone. It's my pleasure to introduce Dr. Alok Kumar Singh, who is Senior Interventional Cardiologist at Alok Heart Clinic and Sinus Hospital, Varanasi, and he is Founder Editor-in-Chief of Chief Heart India, Chief Trustee Heart India Charitable Trust, and Vice President of API Varanasi branch. And he has vast experience in performing more than 5,000 interventional procedures like CAG, PCI, PPI, ICD, CRT implants, and more than 80 publications in various national and international journals. He would be speaking on the current guidelines in the management of heart failure. Dr. Alok Kumar Singh, please.
First of all, I would like to thank Dr. Singh for giving me this opportunity. Coming to Allahabad for me is always nostalgic feeling. I did my schooling from here only. My father had worked in electricity department for here in Allahabad for 35 years. When I got selected in BHU, then my whole family shifted to Varanasi because my village is nearer to Varanasi. But Allahabad is always very close to me. Whenever I got the opportunity, I always come to Allahabad. And after passing my DM, I have worked for 9 months in Saraswati Heart Care. So my practice career also started here only. So it is always a nostalgic feeling, and I always feel good when I have to visit Allahabad. So the topic allotted by Dr. Abhishek is heart failure current guideline classification. And one important thing here added, are all going to die? Whenever we talk of any organ failing, then suddenly in our mind comes, these patients have a very dismal prognosis and this is not going to survive. But it is not so. The terminologies have a wider meaning and wider implications. So we have to understand, and for a very long time, heart failure, there was not a very single definition. And it was difficult to define heart failure. A lot of trial has been done, a lot of guidelines have come, and all studies have used the different definition. So there was a need to unify the definition of heart failure. So the American College of Cardiology, European Society of Cardiology, and Japanese Cardiovascular Society came together, and they came with a document in 2021. That is a universal definition of heart failure document, where they have for the first time have given the single definition of heart failure, which will be followed by the all international guideline. What it is? So definition of heart failure is a clinical syndrome with a current or prior. First thing, which is very important, symptoms and signs caused by any structural or functional cardiac disease. This is a must. And corroborated by at least one of the following. One is elevated natriuretic peptide level or objective evidence of cardiac, pulmonary or systemic condition. So there must be symptom and sign because of structural or functional cardiac disease, and it must be corroborated by elevated biomarker or objective evidence of cardiac and pulmonary condition. So this is a universal definition. It will be taken, it will be universal. There will be no second definition adopted by any society, international society. And apart from that, Another concept in heart failure which is very important to understand is staging of the heart failure. For the comprehensive management of the heart failure, this staging is very important. For the first time in 2001, American Society of Cardiology came with this concept. Now it has been further refined. And stage A is the person at the risk of heart failure. Means patient does not have any symptom and signs of heart failure, does not have any structural heart disease, does not have any elevated cardiac biomarker disease, but have the conditions like coronary artery disease, hypertension, diabetes, or exposure to the cancer drugs. If you will not tackle these conditions properly, then these patients can go on develop structural heart disease and can lead to the heart failure. So as there was a talk in the morning by the director of DGHS, we can primordial prevention, we can act before occurrence of the heart failure. So if we can treat hypertension effectively, if we can treat coronary artery disease effectively, diabetes effectively, dyslipidemia effectively, then we can prevent the occurrence of the heart failure at the outset. So that is a stage A. Second stage B is a pre-heart failure, where there is a structural heart disease, there is an abnormal cardiac function, abnormal cardiac biomarker have been detected incidentally, but there is no symptom and sign. Suppose any patient came for the surgical clearance and you did the ECG and echocardiogram. On echocardiogram there is a structural heart disease, but patient says I don't have any symptom. Then you will label this patient as a stage B heart failure. What is stage C? Stage C is a patient with current or prior symptoms of heart failure in the presence of structural and functional cardiac abnormality. This is stage C. That is what we treat in our OPDs and altogether. And last stage is advanced heart failure. Severe symptoms and signs of heart failure at rest despite all optimal medical therapy, having the recurrent hospitalization. So stage A is primarily a disease of physicians. You have to tackle hypertension, diabetes very aggressively. Stage C is basically a disease need to be treated by cardiologists, and advanced heart failure is basically goes into the domain of cardiac surgeon, where LVSS devices and cardiac transplantations are being done. After staging, classification is very important. Classification is based on the ejection fraction. If it is less than 40%, HFrEF. If it is more than 50%, heart failure with preserved ejection fraction. If it is a 41 to 49, it is a mildly reduced one. And another is heart failure with improved ejection fraction. If it is earlier less than 40%, have improved more than 10%, and second measurement is more than 40%, then it is labeled as a heart failure with improved ejection fraction. One very important thing, as a physician I have seen, when they repeat echocardiography, when you see the changes in ejection fraction, then most of the physician complains, sir, पहले तो इसका ejection fraction ऐसा था, आपने अब इतना दे दिया. So I want to make it clear, ejection fraction is a dynamic number. It is a load dependent entity. Even within 1 day or 2 days it can vary. So it is important to note, don't be dogmatic with the ejection fraction numbers. And in latest 2022 guideline, ACC have acknowledged this fact, and they have specifically mentioned any patient in HFrEF can improve over the period of time with treatment, without treatment. Then you will label it as a heart failure with improved ejection fraction. And patient in heart failure with mildly reduced one, it also can improve or worsen. Even in preserved one, also it can worsen or worsen only. So how much can improve and worsen in HFpEF? Approximately 60 to 90% remain in the same group. 10 to 20% can worsen into the heart failure with mild reduced ejection fraction or reduced one. And HFrEF, 10 to 20% can improve to the mildly reduced one, and 10 to 20% can improve with the heart failure with preserved ejection fraction. So ejection fraction can improve, can deteriorate, and can remain in the same category. So we cannot be the dogmatic about the fixed values, but still ejection fraction is very important because most of the therapies which benefits have been shown to be beneficial in heart failure with reduced ejection fraction only. Now coming to the does heart failure is always dangerous, all patients are going to die. So very elegant study came in New England Journal of Medicine in 2000, where for 15 years at Johns Hopkins they have followed approximately 1200 patients and very thorough workup, even endomyocardial biopsy was done. They have found approximately 50% of the patients with the idiopathic dilated cardiomyopathy, 50 out of 1251 peripartum cardiomyopathy, approximately 111 was a myocarditis, and during a mean follow-up of 4.4 years, out of 1200 around 417 patients died and 57% patients underwent cardiac transplantation. So approximately 480 patients out of 1200. So approximately 40% patients, if you remove cardiac transplantation, which is not very common in our place, so approximately 40% patients died over the period of 4.4 years. But mind it, this is a study published in 2000. At that time, only ACE inhibitor in heart failure was common, and diuretics were given. But when we further dissect this study based on the etiology, which is very important. You can see here, if your heart failure is because of peripartum cardiomyopathy, survival is very good. Even up to 15 years, 90% of, more than 90% patients survive with diuretic and ACE inhibitor only. And even idiopathic dilated cardiomyopathy, which we see most common is this, up to 15 years, you can see more than 50% patient is surviving. Worst prognosis is cardiomyopathy due to HIV infection, and then infiltrative myocardial disease like amyloidosis, and then doxorubicin. But when we combine together, then prognosis looks very poor. But when you dissect based on the etiology, it is not like that. So every patient is different depending on the age, depending on the etiology. So in heart failure, functional status matters, ejection fraction matters, and etiology matters. That message I want to give. So the conclusion is of this study was the underlying cause of heart failure has a prognostic value in patient with unexplained cardiomyopathy. So look for that. Another very elegant study by William Dent, published in 2014, Natural History of Acute Dilated Cardiomyopathy. Here, 373 patients from the 12 academic medical centers, LV of less than 40%, heart failure symptom less than 6 months, and proven cases of idiopathic cardiomyopathy. Here, almost 40% of the patients have improved on treatment, and 1 year survival was 94%, 2 year survival was 92%, and 4 years was 86%. This was before early era, mostly on the ACE inhibitor and beta blockers. Another study which came in 2007 in Circulation, they have dissected this on the basis of staging of the heart failure, stage A, B, C1 and C2 and D. C1 and C2 based on the Framingham criteria. Even with the modern staging, the patient with the Framingham criteria positive have a level like the C2. You can see C1 patient, which the Gordon variety is, approximately more than 50% patients survive up to the 8 years. So the staging is important. This study have told. And then the 2019 meta-analysis reported that 5-year survival rate for people under the age of 65-year age was around 80%. And about 50% age 75 year and over. So the prognosis is not that much poor if you take overall comprehensive picture. And in 2019 European Society of paper, up to 35% survival rate is up to 10 years. So prognosis is improving with the medical management. Now coming to the treatment part. So the message is overall etiology, age, staging, ejection fraction you have to take into the account. And the modern medical therapy have evolved very much. How the treatment have evolved over the period of time. Before 1987, we all treat heart failure with the diuretics, digitalis and vasodilators. In 1987, consensus trial came for the first time. Enalapril has been shown to reduce the mortality in significant way. Then in 1996, US carvedilol program has shown there is a 65% reduction in mortality and 27% reduction in the risk of hospitalization by the carvedilol. Once upon a time, beta blocker was considered as a heart failure, was a contraindication for heart failure. We used to study in our pharmacology textbook. And in 1999, the RACE trial came, which has shown spironolactone is a very effective drug in reducing 30% mortality in heart failure patients. Then 2014, paradigm HF, ERNI came, secuitril-valsartan, and lately this is a SGLT2 inhibitor. So we are having a very wonderful class of drugs which have really impacted the natural history of heart failure in a significant way. Now coming to the direct management. At risk of heart failure, stage A. Stage A means patient is having hypertension, no structural heart disease. You have to treat hypertension very effectively if you want to avoid heart failure. If you are having diabetes and you want to prevent heart failure, SGLT2 inhibitor is a class 1. You can see all green is a class 1. So ESC and SEC recovered is a SGLT2 inhibitor as a class 1. Cardiovascular disease like coronary artery disease you have to treat effectively by intervention or medical management. Cardiotoxic agent exposure, as cancer is increasing like anything and they are having a very cytotoxic drug, so you have to manage effectively. And the patient at risk of heart failure, natriuretic peptide screening is a class 2 recommendation. So you can screen your patients whether their biomarkers are increasing or not. Now coming to the stage B, where there is a structural heart disease is present, patient is not overtly symptomatic. You have incidentally detected the structural heart disease. So here there are 3 therapies is a green. One is ACE inhibitor, another is beta blocker, and another is implantable cardiac defibrillator if it is a ejection fraction is less than 40%. So in stage B, when there is asymptomatic LV systolic dysfunction, only ACE inhibitor and beta blocker, these two class of drugs are recommended. ERNI is not recommended in NYHA class 1 by the guidelines. So ACE inhibitor and beta blocker is recommended if patient can afford, then ICD can be given. Now coming to the stage C. Stage C means symptomatic heart failure, means NYHA class 2 to 4, and these 5 green. ERNI in NYHA class 2 and 3, ACE inhibitor or ARB, NYHA class 2 to 4, beta blocker is a class 1 recommendation, MRA like spironolactone and eplerenone is a class 1 recommendation, SGLT2 inhibitor, dapagliflozin and empagliflozin and sotagliflozin is a class 1 recommendation. ACE inhibitor is a class effect, but beta blocker is not class effect. All beta blockers cannot be given in heart failure. Metoprolol, succinate, carvedilol and bisoprolol. These only 3 beta blockers are recommended to be used in heart failure. Even metoprolol tartrate, that is came in the name of beta Alok, is not recommended to be given in the heart failure. You can give in MI and CAD, but not in heart failure. So you give all these 4 medications. If still your ejection fraction is not improving, then you can, in African American hydrogen isoside dinitrate recommended, and if patient is having LVBB, then CRTD is recommended. If still your patient is not improving, refractory heart failure is there, then you have to consider for cardiac transplant or LVSS devices. If all these are not options, then supportive treatment is the option. So, refractory heart failure is basically domain of cardiac surgeon. This stage C is basically domain of cardiologist, and stage A and stage B basically is the domain of physicians. So that's how we manage. And after this ACE, ARNI, beta blocker and all, still if your patient is not improving, then what option we are having? Diuretics for the symptomatic treatment. If patient is still not improving, hydrogen isosulfide dinitrate is a very good option. Especially this drug is very useful if your patient having a kidney dysfunction. Then you cannot give ACE and ARNI. Hydrogen isosulfide dinitrate is a very good option. If in spite of all maximum tolerated beta blocker, heart rate is still more than 70, then ivabradine is a drug of choice. You can add further to improve the prognosis. And if your patient is having recurrent hospitalization in spite of all previous therapies, then variciguate is also an option. So now we are having multiple options which can impact the prognosis of heart failure. So I think now coming to the which drug is most effective. This table is from the American College of Cardiology guidelines. Here you can see relative risk reduction in all-cause mortality in pivotal randomized controlled trial. Maximum relative risk reduction in mortality is by the beta blocker. It is a 34%. So, most effective drug in reducing the cardiovascular mortality is a beta blocker drug. And there was a very elegant analysis published in JAMA Cardiology where they have compared in comparison to placebo which drug is most effective. Again, they came with 5-year number needed to treat. It is a minimum with the beta blocker. Minimum the number, most effective the drug. So, only 8 patients need to be treated to gain the one survival over the 5 years. So, beta blocker is the most effective drug, followed by ARNI, followed by ACE inhibitor, and followed by CRT and ICT. So, beta blocker is the most effective drug, followed by ARNI in this meta-analysis. Now the question comes, when what to start? So classical teaching was that before 2022 guideline, first start with the ACE inhibitor, then add beta blocker, then MRA, and if patient is stable, then go with the ARNI, then go the SGLT2 inhibitor. But it has been seen, it takes very long time to add all 4 drugs, and it does not have any scientific basis. It is only on the basis the way it has been discovered in the trials. So now rapid sequencing is recommended. Start with the beta blocker and SGLT2 inhibitor. Why SGLT2 inhibitor? Because it has a diuretic effect, so it will give the symptomatic benefit, and beta blocker reduces the sudden cardiac death as well very effectively. Most effective drug in reducing the sudden cardiac death in heart failure is beta blocker. So combine with the beta blocker and SGLT2 inhibitor. Wait for 2 weeks. After 2 weeks, consider for ARNI. After 2 weeks, add MRA. And MRA and these can be interchangeable. You can start MRA before ARNI if BP is low, because ARNI known to cause hypotension. So because of hypotension, if you are not able to add ARNI, then start MRA before and ARNI. Now the recommendation is try to add all classical 4 drugs within 4 weeks at the minimum dose, and later on increase the dose. That is the latest concept. So, according to an elegant analysis by Vadugnathan et al., if this 4 drug strategy, if you adopt in a 55-year-old patient, you will get additional gain of 8 years free from cardiovascular death or first heart failure hospitalization. So, this is very effective if you add all this. Very recently, a paper came. Even simply by adding ACE inhibitor and ARB and beta blocker versus no guideline directed medical therapy, there will be absolute risk difference of 15% approximately. And if you all 4 combine, there will be absolute risk difference of approximately 25% within 1 year. This paper came in 2024, very recent. So try to add all 4 drugs even with the smaller dose, like a hypertension concept, combination therapy in hypertension, with a low dose of all 4 drugs, as early as possible. What are the factors? Non-ischemic etiology, chances of ejection fraction improvement is very high. Shorter heart failure duration, if within 6 months, it is very high. Lower the ejection fraction. If you start with the lower ejection fraction, chances of recovery is high in comparison to the higher one. And if there is no late gadolinium enhancement, now MRI is coming in very big way. If you are able to do MRI, there is no late gadolinium enhancement and ejection fraction is poor, then very high chances on medical therapy these patients will improve. And the biomarker, higher biomarker and rising biomarker, if it is there and it is decreasing with treatment, then again there is a very high chances of reverse remodeling. So by these things, females have a better prognosis. So these things you can incorporate in day-to-day practice. Another very important question comes: if patient ejection fraction has improved, can we stop the drug? Because always nobody want to take drug. So it was a thought, it was studied in ESHF study where they stopped the drug in one arm where the heart failure ejection fraction was improved. But what I have seen, there was a relapse of 44% within 6 months. So even with the ejection fraction improves, don't stop the treatment except in few conditions like peripartum cardiomyopathy, the reversible cardiomyopathy like tachycardiomyopathy. So these are the conditions where you can stop the treatment. Otherwise, you cannot. So summary, heart failure is not a single disease. So single site does not fit to all. Etiology matters, EF matters the treatment outcome. Start all 4 drugs in 4 weeks. Try to maximize your target dose in 3 months. Our aim is decongestion, reduction in sudden cardiac death, reduction in heart failure, hospitalization, reverse remodeling. These should be our aim. For decongestion, we are having 2 drugs, loop diuretics and SGLT2 inhibitor, reverse remodeling, beta blocker best, early and CRT, sudden cardiac death, all 4, early MRA, ICD and SGLT2 inhibitor, beta blocker, reduction in heart failure, hospitalization, all 4, plus vericiguat, tachycardia, if there is a tachycardia, beta blocker and evaporating, if there is a AF, digoxin is need to be added, and comorbidity management is also the fundamental part of it. So that's all about heart failure. Thanks all for patient care.
Completing the lecture in time because we are already running late. And it was a very good comprehensive review of the current management of heart failure. And the take-home message is that any patient with symptomatic heart failure, the prescription should contain beta blocker, a loop diuretic, MRA, that is spironolactone or eplerenone, SGLT inhibitor, irrespective whether the patient is a diabetic or non-diabetic, and ARNI, if the blood pressure permits. And you have to gradually increase the dose depending on the patient tolerability and response. Lanoxin is only indicated now if the patient has atrial fibrillation. Otherwise, lanoxin or digoxin is out of prescription of cardiac failure. And of course, refractory heart failure, which are not responding to medical therapy, then we have CRT where the indication is CRT-D or maybe heart transplant as a last resort. Comments from Dr. Piyush and then we open.
Thank you so much, Dr. Alok. I just wanted to query, what is the minimum dose of RD you are using in your clinical practice and what is the maximum you are experiencing? What is the maximum dose that you are able to take your patients of RD to, and what is the minimum dose that you think would be better? Because I have seen someone prescribing sacubitril valsartan 50 mg 1/4 tablet daily. So that is my query. Just as on your experience, what do you think?
If you see early, the real problem in static hernia is a hypotension. As you will agree to me, our patient which we see in our day-to-day practice, they come in at very advanced stage. So they have very low blood pressure. So with early problem is that once you start with the higher doses, there is a chances of hypotension. So if, as have been recommended, what I practice I am telling, I always start with the beta blocker and SGLT2 inhibitor as your first drug. What is the rationale why I do? Because SGLT2 inhibitor have a diuretic effect and initiating dose of SGLT2 inhibitor and the maximum dose is the same. So the day one you got the maximum dose. And I start earlier in the last. Beta blocker and SGLT2 inhibitor, and then I start with the eplerenone. Because here also the starting dose and maximum dose is more or less same, 25 and 50 mg. Most of us start with the plus combinations for the diuretic effect. So already we have a torsemide and spironolactone combination where you have a full dose of spironolactone day one and you have dapagliflozin or empagliflozin full dose, and usually I prefer carvedilol if there is no history of COPD and all. So from day one you can start with the 3 drugs. Early, if blood pressure is above 110/70, then I try to start with the 50 mg BD. If it is less than, I want to stop, wait for 2 weeks. Because after starting diuretics and all these drugs, blood pressure comes up. And once it is around 110 and 70 only, then I go with the 50 mg BD and ask the patient to come daily. If blood pressure is lowering, then I go with the half BD. Otherwise, I continue with the 50 mg BD. So once you are starting with early, be careful with the hypotension, because hypotension is a problem. And another issue is once you are starting MRA and early together, there is a chances of hyperkalemia. As you will agree, our patients are very poor in follow-up. Having potassium every 3 days, 4 days is a very difficult task. So at least I give 2 weeks separation in starting MRA and early. That is my usual practice.
Sir, if I may. I think just to answer this, what I would suggest is most of the times diuretics need to be taken off the table as quickly as possible. Diuretics are just to decongest. Plus what torsemide does is causes more renal dysfunction. So as sir said, yes, SGLT, it's a very personal choice, but SGLT2 or ARNIs, either one need to be started. The problem with ARNI is never hypertension. You need to give ARNI, call the patient back in 3 days, increase the dose ARNI, go from 50 BD to 75 to 100. Our target has to be 200 BD at some point of time, even if the blood pressure is 100/70. Because your maximum benefit with ARNI will be at 200 BD, it will not be at 100 BD. As soon as you take out diuretics, and as you keep increasing ARNI, the blood pressures will come up. The problem becomes is we keep the patient on Ditor plus most of the times, and that Ditor causes a problem. Even if the creatinine is worsening, even if the creatinine has gone up to 2, ARNIs would not make a difference because they are not contraindicated until and unless there is hyperkalemia. So do not wait for the creatinine that it's gone from 1.1 to 1.5, we need to stop ARNI. Do not, it will improve. Once the renal perfusion improves, the creatinine will start coming down. The only problem that is causing creatinine rise is the Ditor there, not the ARNI.
But the problem is in follow-up actually.
Follow-up is
a real issue. That's why, because it's patient decides when he will come.
I completely agree with you, sir. But what my question initially was, starting a dose of 50 milligram of sacubitril/valsartan, 1/4 tablet, does it have any rationale?
It has no rationale.
It has no rationale. That is what I want to
Even 90-60 blood pressure, 50 BD is a good dose.
Good dose. People are giving 1/4 tablet BD, that has no rationale and it's not going to do any good. Thank you so much, Dr. Alok, for such an excellent talk. The floor is open to question if anybody needs to ask.
Sir, there are 3 beta blockers have been approved in heart failure. One is carvedilol, another is metoprolol succinate, the third one is bisoprolol. If you ask me my personal, then I go with the carvedilol. because carvedilol gives lot of dose titration capability, because you can go with the 3.125 to the 25 mg/d. The type of patient which we get in our part of country, they really come with a very advanced stage of heart failure to the clinics. They have hardly, most of the patients have very low BP, lot of comorbidities. So blood pressure for our patients still matters, what I feel.
मेटाप्रोलॉल तो अभी कुछ देर पहले ही बताया गया कि हार्ट फेलियर में नहीं दीजिए until unless the patient is also a cardiac one. So हाँ तो अभी आप बोल रहे हो उसको दो तो take home message.
Sir, it was in heart failure, beta blocker is the most effective drug. You have to decongest the patient, make the dry patient and give it. So I think a message.
I think just look, I'm not here to contradict you. I'm Dr. Pandey, I'm cardiologist at Max. See, there are three beta blockers, standard beta blockers. One is carvedilol, metoprolol, and bisoprolol. If you look at the heart reducing, see why beta blocker? You want to bring down the heart rate to around 60, 70. So beta blocker is a your choice, but a patient has a borderline hemodynamics. Corbis bisoprolol is the best beta blocker because it does not disturb the hemodynamics. So pressure 100 by 60. First of all, the number of pressure 100 by 60, 90 by 60 is just number. Is patient hypertensive? Does he have the signs of hypertension? Orthostatic hypertension. The patient does not have orthostatic hypertension. I continue my heart failure medication even 80 by 60. So borderline pressure, because the strongest beta blockade is with bisoprolol. It's most safe, even in the COPD. Second is metoprolol. Carvedilol is very strong beta blocker. It has alpha blocking properties. So if my aim is to control blood pressure and heart rate both in CHF and heart failure, I prefer carvedilol. That is how we go. And metoprolol, see, they are all good. Indication of beta blocker is to bring down heart rate. And by default, if you can't bring down heart rate by beta blocker due to different reasons, maybe hemodynamics, it is ideal time to add ibuprofen because it's just totally hemodynamic neutral. It doesn't bring down heart blood pressure. So this is how I combine. Dr. Alok, two things I would like to add. We forget metabolic profile of a patient. I have seen a lot of patients who are having heart failure, hemoglobin is 10, 11, and we presume that they are alright. Do check their iron studies. I think if 4 drugs are pillars, these 2 drugs are a scaffold. One is iron therapy. There is a lot of Ironman study has come. They say that they improve morbidity, but I think any drug which is improving morbidity today, they improve 6-minute walk distance. Tomorrow that same drug will bring down mortality also. So good iron therapy and good ibuprofen, beta blocker of your choice, it is individual choice. Army must be given. And SGLT2s, and then acute stage, I don't write SGLT2s because you have to restrict fluid, and patient who has been discharged from hospital has been catheterized, they have very high chance of UTI. So it is 4 drugs, 4 weeks, which order, it is total your choice.
Let me clarify a few things. Very recently a trial come with the sotagliflozin. And sotagliflozin in acute heart failure, it's a very effective drug to reducing the heart failure hospitalization. And another very important concept, selective versus non-selective beta blockers. It is very well established. If you see carvedilol has the maximum data in heart failure. US carvedilol study which have shown, it has shown the 65% reduction in cardiovascular mortality. Bisoprolol has a series series of trials, series 1, series 2, series 3, and it has shown 34% reduction in mortality. Metoprolol, ESHF, 34% reduction in mortality. Non-selectivity is not always worst. Propranolol and carvedilol, it has been shown to be reduced ventricular arrhythmia burden. There is a study, and if you will ask electrophysiologist for VT reduction, if there is a recurrent ventricular storm is going on, VT is going on, non-selective beta blockers are preferred. But sir is right, when there is a COPD, when you need cardioselectivity like a COPD population, then bisoprolol is a very good choice. personal preferences there, but if you will go with the evidence, the maximum evidence in heart failure is with the Carvedilol. In post-MI patients, bisoprolol does not have any post-MI data, but Carvedilol has.
Okay.
So if there is no bronchospasm, I use it.
I think Abhishek, you have to give one separate session on this heart failure next time. Yes, we need a complete, it is an endless topic and we can discuss whole day and night. Yes.